Hey everyone, today's topic is on fluids, and this is a deceptively simple sounding topic that actually has some decent nuance to it. So we'll start this video by talking about why fluids are such an important topic for really any type of physician. We'll go over the basic types or classifications of fluids and how they are used. Then we'll touch on just a little bit of physiology to help us understand that fluid selection instead of just memorizing different types for different situations. Then we'll talk about how to dose these fluids, and I really want you to think of fluids like a medication that you're dosing. It sounds innocuous. Oh, we're just giving people fluids. We're giving them their daily water requirement. But we found that overdosing people with fluids, causing fluid overload, can actually have quite significant adverse effects. So it's really important to get the dosing right. And then finally, we'll finish up with my way that I keep fluid selection simple for my services, and hopefully give you a nice rule of thumb for fluid selection. So to start, why should we care about fluids? The two big uses of fluids are maintenance. So when you're essentially trying to maintain a patient's body fluid content, remember we're drinking a certain amount of water every day. So patients who are NPO, which is very common in the hospital and especially in surgical patients, um, they need to get their fluid through intravenous means. And then the second option, or the second real major use of fluids, are resuscitation. And that I like to think about it as just an acute imbalance in the patient's fluid status. So they've lost some type of fluid and you need to acutely replenish it, either just fluids themselves, for example, in something like septic shock or dehydration, or even blood. So if somebody's in hemorrhagic shock, then you need to replace that blood, replace what they've lost with a resuscitated fluid, specifically in that case, blood products. And something to keep in mind as we're going through this, I don't know if people still listen to Golian's audio for step one review. I suspect it's probably gone by the wayside, but when I was using it, the phrase that he had was give them what they lost. So whenever we're thinking about fluids, we're going to think about what type of fluids that they lost and then replacing them with the fluids that are most similar to those fluids. So in maintenance, that's usually some sort of crystalloid solution, isotonic crystalloid, and then in resuscitation, obviously, if you've lost blood, the thing most similar to blood is blood itself. So just keep that in mind as this video goes on. So here are basic types of fluids. These firstly all really refer to electrolyte content. So hypotonic fluids, of course, have less electrolytes in them than blood. Isotonic fluids have a similar amount to blood, and then hypertonic has an increased amount of electrolytes compared to blood. Blood, of course, or I should say blood products, are, of course, essentially identical to blood. They're a little bit different because of how they're stored, but you can think of them as essentially a blood equivalent. And then colloid is a little bit unique, where instead of maintaining tonicity with electrolytes, we really are focused on osmotic pressure with these big proteins like albumin. And we'll talk about that a little bit more on our physiology slide. So how do we use these fluids? Remember, we have our two uses. We have maintenance, where you're just getting the amount of fluid you need for the day. We have resuscitation, which is when you're acutely replacing something someone's lost, really treating them for some sort of disease. And then finally, there's this other category that we're not going to talk about today because it's so rare and situation specific. So hypotonic, remember, these are fluids that have less electrolytes than blood. Those are really only used for maintenance. We'll talk about why you should never use a hypotonic fluid for resuscitation on a later slide. Isotonic is really flexible. So these are kind of they can do anything. So you can use maintenance, use those for resuscitation. It's almost never wrong to pick an isotonic fluid. Hypertonic is a really rare fluid to use. That's mostly used for certain types of sodium disorder, either renal disorder or neurosurgery likes to use them a lot in trauma to try to mess with cerebral swelling. Blood is blood, so of course that's an excellent resuscitative fluid if the patient's lost blood, but we really don't want to give people blood unless they really need it due to things like transfusions reactions. And then finally, colloid. It can be used as a resuscitative fluid, but it's not really used very much because it's a little bit more expensive than some of the other fluids. It has not been shown to be superior to the isotonic crystalloids. It's also used in some other situations, for example, liver failure. But again, those are specialized. We're not really going to focus on those today. So for the purposes of this video, you can pretty much not think about hypertonic or colloid solutions. So Now, I don't want you to really have to memorize, oh, I use this for this, this for this. I want you to understand it. So that's what we're going to cover in this next slide. And so there's a lot of numbers on this chart. Really, you only need a few simple numbers when you're thinking about how the body fluid system works. So to start, we'll divide right here with our intracellular versus our extracellular fluids. And remember, our body is mostly made up of cells, so most our water is intracellular. So that's 2/3 over here. I'm kind of using the terms water and fluid interchangeably. And we have 1/3 of our fluid over here. So 2/3 and 1/3, those are our first two numbers. And within this 1/3 of extracellular fluid, we have 3/4 and 1/4. So when we talk about total body fluid, 2/3 of that fluid is intracellular and 1/3 of that is extracellular. Of that extracellular fluid, 3/4 is that interstitial fluid, and then only 1/4 of that is actually your blood volume. And for the average human, you have around 5 liters of blood. So if you just remember those few numbers, 2/3 and 1/3, 3/4 and 1/4, and 5 liter, those are really all the numbers you need to be familiar with. But actually, you don't really need those numbers. What they're going to help us to do here is show you how the different sorts of fluids that you might give someone IV distribute within the total body fluid volume, and how that informs our selection of fluids for these various clinical scenarios. So I mentioned Golion before. The other big phrase he had, besides give them what they lost, that really stuck with me was that we usually think of giving volume as the fluid is the volume, but his big point is that salt is volume, not fluid. And what did he mean by that? So to understand that, we have to talk about what separates these different fluid compartments. So here's one boundary between the intercellular and the extracellular fluid. And this is, of course, just maintained at that cellular membrane. So this is there's a significantly different electrolyte content between these intracellular fluids and these extracellular fluids. Those are maintained by different transporters, such as your sodium potassium pumps, etc. But for our purposes, what you need to think of is that something like water will fill all of these compartments, but something with an electrolyte makeup that's similar to that of blood will not cross this barrier and will be stuck completely in the extracellular fluids. Then our other barrier is this barrier between the interstitial extracellular fluid and the blood itself. And that's a more porous barrier. So I'm drawing this with some holes in it. And so since it's not this tight, lipid bilayer like we have at the cellular level, these layers, fluid can move more between cells. And the pressure that keeps the blood in the blood compartment as opposed to going in the interstitial compartment are these big proteins that we have in the blood. That's, of course, the blood cells, other proteins, albumin's probably the biggest one. And so we call that the oncotic or osmotic pressure that keeps the blood volume within itself. So when you give somebody something like blood, that will stay just in this compartment. Whereas if you gave somebody something like an isotonic crystalloid, that would go in this entire extracellular compartment. So a lot of points there, but what's the clinical takeaway? So if we give somebody water, the way you might do that is to give them a solution called D5W or D5 water. Let's say you give them 1 liter. So that liter is going to spread throughout the entire body fluid compartments. So when you think about it, what we're typically giving fluid for in the hospital is trying to replace somebody's blood volume, at least when we're talking about a resuscitative situation. Of course, maintenance is a little bit different. So if you're trying to replace blood volume, you give a liter of D5W, only 8% of that, or 80 cc's, is actually going to go into your circulating volume. So you can see you're not going to replace the blood volume very effectively. While you're trying to give enough D5W to do that, you're going to greatly fluid overload them because all that fluid is going to be moving from the blood where you give it into all these other bodily compartments. So we need a fluid that's more specific. So let's try maybe an isotonic fluid like LR. So if you give 1 liter of LR, remember that has an electrolyte makeup isotonic to the level of the extracellular fluids. That will not cross this barrier between the intracellular and extracellular fluids. So it's only going to go in this in these two body fluid compartments. So remember, our numbers here are 3/4 and 1/4. So if we give a liter, 1/4 of that is going to be 250 cc's. of LR going into the blood compartment, which is obviously much better than 80 cc's, but still, relatively small when you think about it. You're like, oh wow, that's only 1/4 of the fluid that I'm giving is actually going to stay in the blood compartment. And finally, you could give something like blood itself. And of course, blood has the same physiologic makeup as blood itself, the blood products. So if you gave, for example, a liter of blood, that would stay completely in this blood or, um, let's just call it the blood compartment. And so that would be the equivalent of giving 1 liter. Of course, you don't usually give blood in 1 liter boluses. Those are usually given, for example, in a unit of packed red blood cells, which is usually around 300 cc's. But if you think about, someone bled out a liter, if you give them just essentially 3 units of packed red blood cells, you're replacing essentially that entire volume in that situation. Of course, there's a little bit of nuance to this because you don't usually want to just transfuse blood with blood. You want to give a balanced resuscitation of packed red blood cells, FFP, and platelets, but going into detail on balanced transfusion is a little bit beyond the scope of this talk. We could always do it in a later talk if you're interested. So thinking about those compartments now, remember we have intracellular, extracellular, and then the extracellular is split into interstitial and the blood compartment. Let's look at the chemical makeup of some of these fluids. And so we can just kind of confirm and understand where these fluids go and then what some of the strengths and weaknesses of the different fluids are. So we have D5W. This is a pretty prototypical example of a hypotonic fluid. Then we have normal saline and LR. These are your prototypical examples of isotonic fluids. And finally, we have the physiologic blood, not blood products. Those are going to be a little bit different because of storage, like I said, but really what the blood makeup is supposed to look like. So the first thing to notice is that everything has an osmolality, I believe it's osmolality, maybe osmolarity, but that's all relatively similar to plasma itself, right? And that's really why there is D5 in D5W, because if we just gave pure water, the osmotic gradient would actually be quite toxic to cells. So you give D5W, so its osmolality is relatively close to that of plasma. It doesn't disrupt the cells, but then when the glucose gets taken up and digested, the water itself is able to spread out across all of our compartments. We see here normal saline, 300, LR, 273. So all about the same there. Of course, D5W is just water, so we have none of these electrolytes. Normal saline, and normal saline is 0.9%. There's other varieties like half normal saline, that would be 0.45%. There's hypertonic saline, which would be usually 3%, or there's even some higher solutions. But for the sake of this, the isotonic, the normal saline is 0.9%. That's half sodium and half chloride. You'll notice that it's a little bit more acidic than blood is, and you see that the chloride is much higher than normal blood chloride. So that's the common problem with normal saline, is that overloading people with this can cause a hyperchloremic acidosis. You can see that it just lacks some of these other electrolytes that are present in normal blood. Compared to normal saline, lactated ringer, while also being an isotonic fluid, is much more physiologic. We see that the sodium is not so high, it's closer to normal. We see that it has some potassium in it, some calcium. Its chloride is much closer to normal as well, so it's less likely to give you that hyperchloremic acidosis. Similar bicarb, and the pH is also a little bit closer to physiologic. What people will point out with LR is that it does have potassium. So in somebody with renal failure and their potassium's high and you want to resuscitate them, some people will say, oh, well, you shouldn't give LR because it has potassium. However, other people would point out that you could replace somebody's entire blood volume with LR and that the level would only be here at 4, and that would still not be above your physiologic level. But really, the more important thing is that they've actually done a lot of trials comparing normal saline and LR, and in almost all of them, LR performs better, even in situations of hyperkalemia and acute renal failure. So I personally pick LR whenever I'm choosing an isotonic crystalloid, but of course go by your institutional preferences and just know that that might be a reason people give for using normal saline instead of LR. And then finally, I didn't actually put it on the slide, but our blood products, the issue with those is of course that you can have transfusion reactions, you can have issues with supply and ABO mismatches. So we really don't like to give blood unless a patient absolutely needs it. All right, so we've given you a lot of info now, but just to I really wanted to stop and give some examples here of the different types of fluids because each hospital is going to have a different formulary. And I don't want you to rely on finding a video that talks about your specific formulary, but rather if you just know the basics of hypotonic, isotonic, hypertonic, you can fit whatever options your hospital has into those categories and you can understand when to use which one. So hypotonic, like we said, D5W is one. Another example, and this is just dextrose in water. Excuse me. Another one would be D5 half normal saline, often called D5 half. That's just the same dextrose, but this time it's in a half normal saline or a 0.45% as opposed to the normal saline, which is, of course, a 0.9%. And if you think about your body fluid compartments, the half normal is just going to stay a little bit more in the extracellular compartment, but not as much as an isotonic fluid. When we talk about isotonic, those are your classics normal saline and LR. But we also have some more recently developed physiologic fluids kind of along the LR model, things like plasmolite. I think Normasol is another example. So your hospital might have one of those. All of those fall under this isotonic bucket. Hypertonics, typically normal saline related, so something like 3% normal saline. Blood is, of course, blood products. Then colloids are things like most commonly albumin, but there's also some more synthetic colloids called things like hetastarch or hespan. So that might also be seen at your hospital. Those are not used too much. So like I said, when you're thinking about giving a patient fluids, usually you're going to be thinking about hypotonic or isotonic or potentially blood if the situation calls for it. Hypertonic and colloids should really only be used in very specific scenarios. You should really know what you're doing if you're choosing to order those fluids. And the other potential issue with colloids, like I said, albumin is probably the most common. Those hetastarch and hespan ones, those can cause issues because if you think about what we talked about, colloids, how they work, right? So you have this blood compartment, you need these big proteins to keep the fluid in this compartment instead of escaping elsewhere. And so some of those big synthetic hetastarch proteins have been shown to cause kidney injury, and so they're often not used. All right, so now we have a sense of what the different types of fluids are and some examples in each category, but we really have to focus on the dose. And this goes back to the idea that fluids are a medication, right? It's not like you just drink water at home. That's regulated by a very complex thirst mechanism that helps you stay appropriately hydrated. But when we are choosing to give people fluids, we really have to give them the right amount. Of course, we don't get the therapeutic effect of fluids if we give them too few. If we give them too much, you can get issues with fluid overload, pulmonary edema, bowel edema causing ileus, issues with compartment syndrome, etc. So probably the simplest is if we start with resuscitation doses as opposed to maintenance. So remember, resuscitation means the patient is acutely short on fluids or blood, and you're trying to acutely replace those. So this, obviously, the ultimate dose is based on the clinical situation. But if you're dealing with something like septic shock where somebody's has a clear fluid deficit, then you're typically giving 1 liter boluses of an isotonic solution like LR or normal saline. And you're just continuing to do that until your parameters normalize. So, for example, their heart rate should come down, their urine output should improve, their blood pressure should improve. You kind of keep giving liter boluses until you achieve this goal. Of course, if it's blood loss, then you're going to give blood products. There's nothing replaces blood like blood itself. So if somebody needs blood, you give them the blood that they need. A couple points here. Like I said, we don't want to give blood unless people need it. So usually most places have a transfusion threshold of around 7 grams per deciliter of hemoglobin. And even if they bleed down to something like 8, that's certainly below normal. But we've talked about the bad side effects of blood products. We usually don't transfuse unless it's lower than this 7 gram per deciliter threshold. An exception, though, to that is acute bleeding. So you can imagine if somebody bleeds out all their blood onto the floor or they've bled out a liter of blood, if you check their hemoglobin level at that time, it will actually still say, 13 grams per deciliter or whatever it was before because it has not had time to equilibrate with that extracellular fluid and show that anemia. So, for example, a trauma patient or somebody that you know is acutely bleeding, maybe there's a bunch of blood in their surgical drains. Don't be fooled by drawing a hemoglobin and seeing a level of something like 13 or 14. That their anemia just hasn't had time to catch up to their clinical picture in that case. And those acutely bleeding patients, if they're hypotensive, tachycardic, definitely need blood resuscitation regardless of their hemoglobin level. And your second use of fluids is the one where the math comes in. So when we're talking about maintaining our level of fluids, we talked about this back in one of our previous videos, but the 4-2-1 rule is excellent. That's the one I use to think about. So 4-2-1. So this is all based on the patient's body weight. So we think 4 cc's per kilogram for the first 10 kilograms, 2 cc's per kilogram for the second 10 kilograms, and then 1 cc per kilogram times the rest of their body weight. So you can imagine that this always equals 40, this always equals 20. Once again, if we're talking about adults, where this really comes into play is in kids, and then this equals some value. We add all that up, and we get the amount of fluids that they should be on per hour. What I remember for adults is that it's just their body weight in kilograms. If you do this math, body weight in kilograms plus 40 equals their estimated hourly fluid requirement. But of course, this is just an estimate. So you give that fluid and then you follow usually their urine output, and you can go up or down if they are or are not making adequate urine to find the correct parameters. Like we said before, these maintenance fluids can be either isotonic crystalloids or hypotonic, depending on the situation. I'd just go by your institutional preference. And that really covers it. So to review our talk for today, this is what I would tell you if you were a medical student on my service. I would never fault you for these questions. So if somebody's acutely bleeding, or we should of course say if they're anemic with a hemoglobin less than 7, that patient needs blood products. If you're needing resuscitative fluids, I like to just use LR. It's an isotonic crystalloid. Remember, any isotonic crystalloid would be okay, but LR is more physiologic than normal saline, so that's what I like to use. And then maintenance, remember, you can still use an isotonic fluid for maintenance. I like to use LR for my maintenance as well, but this is probably the maintenance, where there's the most institutional variance. You should just go by whatever your institution does. So remember, just give people what they lost. If they're bleeding, they need blood. If they need fluids, I like to give them what I think is the most physiologic isotonic crystalloid, but really any isotonic, remember, that's what they lost. They've lost isotonic fluids. Give them back that fluid. So for me, I just think LR and LR. And this keeps it really simple. A lot of times these patients, especially if you're resuscitating, are quite sick and you have to make decisions in the heat of the moment. So I found it easy to just make it as simple as possible, make these be your baseline, and then you can only have to memorize these specific instances where there are exceptions. All right, so that's it. Remember, surprisingly complex topic, but I hope these fundamentals will help you navigate the fluid waters. That's a bad pun. These videos are for educational purposes only. Do not use them to diagnose or treat any disease. We'll see you next time.